Hello, everybody. I'm Dr. Anita Saxena, Additional Professor in the Department of Nephrology, SGPGI, Lucknow. Today, I'm going to speak to you about the role of nutrition in preventing progression of chronic kidney disease. Now, we all know that chronic kidney disease is a major contributor to the global burden of non-communicable diseases. The term renal disease embraces a number of clinical conditions whose principal outcome is progressive loss of renal function, development and progression of cardiovascular disease, and development of malnutrition. Now, the three most widely studied interventions linked in their effect on GFR for slowing progression of CKD are lowering of blood pressure, proteinuria reduction, and antihypertensive drugs. And other factors which are instrumental in slowing progression of CKD are strict glycemic control, lipid-lowering therapy, smoking cessation, dietary modifications in terms of protein and salt restriction, lifestyle modifications, antioxidant therapy, correction of metabolic acidosis, and anti-inflammatory therapy. Now, why are these interventions required? So let's have a quick look at the pathophysiology of CKD. Now, pathophysiology of CKD involves two major mechanisms. The initial mechanism is of the specific underlying etiology, like immune complex, glomerulonephritis, and inflammatory mediators to a specific type, or exposure to toxins in some renal tubules and interstitial disease. And two, a series of progressive mechanisms involving hyperfiltration and hypertrophy of remaining viable nephrons due to a long-term disease in renal mass, due to a long-term decrease in renal mass. Now, the hemodynamic factors which play a role in progression of CKD are increase in GFR in every single nephron, which causes protein leak into the tubular fluid. Proteinuria increases, angiotensin II production also increases. Accumulation of cytokines, macrophages, and T lymphocyte cells induce nephrogenic immune response and produce interstitial nephritis. Inflammation causes renal tubular cells to move away from basal membrane and form new interstitial fibroblasts. The fibroblasts lay down collagenous matrix and disrupt adjacent capillaries and tubular nephrons, and this leads to scar formation, and the whole thing leads to glomerular injury and progression of CKD. Now, the non-hemodynamic factors which play a role in progression of CKD are angiotensin II, the aldosterone, endothelin, the acidosis, and oxidative stress, which contribute to worsening progression of CKD through cardiovascular complication, including hypertension, inflammation, fibrosis, and apoptosis, as well as damage to the glomerular filtration barrier. Now, with declining function, the capacity to respond to changes in nutrients and water intake become less flexible, and the solute and water excretion per nephron increases, but the fewer number of functional nephrons leads to more restricted range of solute or water excretion. Now, when diet exceeds daily protein requirement, the excess protein is degraded to urea and other nitrogenous waste, and these products accumulate. Since the severity of uremic syndrome is proportional to accumulation of these waste products and ions, this whole thing, which is because of the uremic syndrome, creates inflammation, cytokine milieu, which causes progression of renal disease, and therefore the dietary intake needs to be adjusted. Now, what are the benefits of nutritional therapy? Nutritional therapy prevents progression of disease and allows a good control of several consequences of disease like nausea, vomiting, anorexia, and even delays initiation of dialysis. So when you see this patient for the first time, the first thing that you have to do is nutritional screening and then go on for nutritional assessment. Now, what is nutritional screening? Nutritional screening is a process of identifying patients at risk of malnutrition so that more extensive nutritional assessment can be performed. It is simple and rapid, and the screening tool addresses 3 to 4 questions like recent weight loss, current body mass index, disease severity, and recent food intake. And this is followed by a detailed diagnostic process, which is nutritional assessment, which is used to monitor course of nutritional therapy. Now, this is a tool for nutritional assessment that is called Subjective Global Assessment, and this is the performer, which has 2 major components, the medical history and the physical examination. Medical history captures information on weight change, dietary intake, gastrointestinal symptoms, functional impairment, and the physical examination takes into consideration the evidence of loss of subcutaneous fat, muscle wasting, edema, and ascites. And based on these criteria, the patient is classified as well-nourished, mild to moderately malnourished, or severely malnourished. Now, here you can see from the pictures a completely wasted individual with prominent bony landmarks causing severe loss of muscle mass and subcutaneous fat. And here you can see the same person, where you can see how prominent his vertebral column is. The scapula, the clavicle is so clear, so prominent, and the rib cage is so prominent. And here you can see there's a complete loss of subcutaneous tissue here and here. And so this is a person who really needs complete nutritional assessment and nutritional support. Now, International Society of Renal Nutrition and Metabolism has come up with a criteria for diagnosing protein energy wasting, which has 4 components: the serum chemistry, body mass, muscle mass, and dietary intake. Serum chemistry takes into consideration serum albumin level less than 3.8 grams per deciliter, serum prealbumin less than 30 milligrams per deciliter, and serum cholesterol level less than 100 milligrams per deciliter. Now, a low serum cholesterol shows that the patient has had chronic nutritional deficiency. Okay, this is chronic nutritional nutrition-based malnutrition. So the second aspect is body mass index, where the body mass index is less than 22 or 23 depending upon age, and unintentional weight loss, which is 5% in 3 months and 10% in 6 months. And muscle mass also, if there's muscle wasting, which is reduced muscle mass for 5% by 5% in 3 months or 10% in 6 months, or there's reduced mid upper arm circumference with regard to the reference population, these are all diagnostic of protein energy wasting. Then the fourth component is the dietary intake, that is unintentional low dietary protein intake, less than 0.8 grams per kg body weight per day for at least 2 months for patients on maintenance dialysis. Or if a patient is in CKD stage 2 or 2 to 5, then protein intake which is less than 0.6 grams per kg body weight per day with 5 grams per day of urinary protein loss. This is again points towards nutritional deprivation. And then unintentional low dietary energy intake, which is less than 25 kilocalories per kg body weight per day for at least 2 months. These are all diagnostic of protein energy wasting. But remember that out of these 4 components, at least 3 components should be present, and out of these 3 components, at least 1 criteria should be there in order to diagnose protein energy wasting. Now, monitor nutritional status with total protein, serum albumin, sodium, potassium, calcium, phosphorus, and % of your usual post-weigh body weight when the patient is on PD. Subjective global assessment, dietary interview, and dietary diary should be maintained and revisited every month. Anthropometry and body composition using DEXA should be done as and when required. Now, what is the role of nutrition in preventing malnutrition and progression of CKD? Now, malnutrition is multifactorial in CKD. Uremia causes anorexia, loss of taste, and because of unpalatable diets and all these 3 things to put together, there is decreased dietary protein intake and energy intake. You have a look at this. This bar chart is showing you that as the GFR declines, the dietary protein intake declines, and the MDRD study has shown that as the GFR declines below 60 ml per minute, the dietary protein intake, energy intake, and serum albumin level, they decline. So, along with reduced dietary protein energy intake, when inflammation, infection, superimposed illness are present, along with comorbidities like impaired gastric emptying, intestinal motility, altered gut flora, microbiota, or metabolic acidosis, hormonal disorders, or increased level of counter-regulatory hormones like glucagon and PTH, declining residual renal function, anemia because of loss of blood due to GI bleed or frequent blood sampling, and then dialysis itself is a catabolic process. So inadequate dialysis again leads to uremia, and during dialysis, the loss of nutrients and water-soluble vitamins in the dialysis also leads to malnutrition. So this is this whole scenario, how malnutrition sets in CKD. Now, what are the problems which are unique to Indian patients with CKD? Basically, Indians are vegetarians, and so vegetarian diets do not have a very high biological protein. Then poor nutrition in general, the lack of proper diet counseling and poor monitoring of nutritional status. Then hyperglycemia, hyperlipidemia, cardiovascular involvement, high incidence of infection, and late initiation of an inadequate dialysis because of financial constraints. And also, when you break this news that a patient has kidneys have failed and he has an ESRD, it is difficult for the family to come to terms, and so the decision of dialysis is also delayed. Now, in early CKD stages, studies have shown that renal-specific diets help protect kidneys from further damage. Low protein diet has an independent therapeutic effect. The dietary protein, causes postprandial hyperfiltration, induces or increases proteinuria, leads to glomerulosclerosis and renal insufficiency. Therefore, low protein diet has an anti-fibrotic effect, and also it lowers hyperfiltration and retards onset of proteinuria and glomerular fibrosis. Protein restriction therefore decreases the percentage of glomerulosclerosis and proteinuria. Even the source of protein has independent therapeutic effects. The feeding studies have shown that plant protein is preferred over animal protein because there is 20% less proteinuria in soya-based diets. Fibrosis is lowest in soya group compared to the casein group. And the feeding studies have already also shown that glomerulosclerosis and tubular dilatation are significantly lower in soya group. Now, reduced animal protein intake reduces glomerular hypertension, reduces renal expression of genes involved in inflammation. Now, when you combine ACE inhibitors with low protein diet, that again has independent therapeutic effect. Low protein diet causes 35% reduction in proteinuria, and this enalapril trial has shown that if you give 20 milligrams of enalapril, it reduces proteinuria by 20%, and it has to be given every day. And if you combine reduced protein intake along with this, then it decreases proteinuria by 30%. So here you can see from this bar chart that the low protein diet combined with ACE inhibitors has lowest proteinuria, this group, compared to the other groups. Now, this is the table which is showing you the KDOQI guidelines for nutrient intake for chronic kidney disease. So let's first talk about the non-dialysis patient, that is CKD stage 2 to 4. These patients require 0.6 grams of protein per kg body weight per day, but if a patient cannot tolerate such a low protein diet, therefore you can always increase protein to 0.75 grams per kg body weight per day. But in case of acute illness, you must increase protein to 1 gram per kg body weight per day. Energy requirement is according to age. If the patient is above 6 years of age, prescribe him 30 kilocalories per kg body weight per day. If the patient is below 6 years of age, prescribe him 35 kilocalories per kg body weight per day, because patients less than 60 years happen to be more mobile, and patients above 60 years are more sedentary. And also, remember, you have to see whether the patient is diabetic or a non-diabetic. If it is a diabetic patient, whether he's below 60 or above 60, you have to prescribe him either 30 or less than 30 kilocalories per kg body weight per day of energy. Now, sodium intake is recommended at less than 2.4 grams. And if blood pressure is uncontrolled, then according to AHA, bring it down to 1.5 grams per day. Potassium should be less than 1 milliequal per kg body weight per day. Calcium supplement should be less than 2,000 milligrams. But if the patient is on vitamin D analogs, then calcium should be restricted to 1,200 milligrams. Otherwise, it can cause soft tissue calcification. Now, phosphorus, again, should be restricted between 800 to 1,000 milligrams, and the phosphate binders must be given to the patient along with meals if phosphorus is raised. Now, cholesterol should be advised as less than 200 milligrams per day, and therefore we advise patients not to take egg yolk, because egg yolk is very rich in cholesterol. One egg yolk contains 250 milligrams of cholesterol, so it is best to avoid egg yolk. But you can always give egg white to the patient. We'll see in the subsequent slides how good egg white is for the patients. Now, vitamin and minerals have to be given to the patients, particularly the water-soluble vitamins and the trace minerals like zinc, because our patients have proteinuria and excessive proteinuria. So, and albumin is something that binds to the zinc. So, therefore, these patients are deficient in zinc, and zinc is important for the proper functioning of 200 to 300 metalloenzymes. And therefore, if your patient is telling you that he's not having good taste, you supplement him with zinc, and you will see the patient will start telling you that he can taste the food is tasting better now. Anemia cannot be corrected through dietary corrections and manipulations. Therefore, correct iron profile and prescribe folic acid, B12, iron supplements, and ESA, and if required, carnitine as well. And 50% of the protein that you prescribe to your patient should be of high biological value, and all the recommendations should be made on ideal body weight, edema-free ideal body weight. Now, these are foods which have protein of high biological value, like milk and milk products, soya products, chicken, egg, and fish. So you should prescribe these to your patients. And this is a typical South Indian rice and lentil-based food or menu. So the South Indians, they menu mainly comprises of idli, dosa, sambar, then utpam, then porridge, then upma here, and all other variations of rice. But remember that we do not give lentils or dals with chilka. So you have to give dehusked dals to your patients. That's why I've put a cross over here. This is pesaratu, which is made of moong dal, which is the chilka dal. So you have to give dal which is without chilka to your patients. Now here is a diet plan, a simple diet plan for a patient from South India. The patient can take sambar and 2 idlis or 1 dosa or 2 utpam for breakfast. And at 11 o'clock, you can give your patient about, a small fruit if he's not hyperkalemic, milk 100 ml, or you can exchange milk with egg white. And at lunch, he can take rice-based recipes like curd, and along with rice, curd, and vegetables. And at between 4 and 5 o'clock, you can give your patient a very high energy supplement, that is sabudana, which is zero protein, but it's very high in energy. And for dinner, the patient can take rice, chapati, and vegetable. So this way, if your patient is 50 kilograms in weight, and if you want to give 0.6 grams per kg body weight per day of protein, that is 30 grams, this whole menu will give him whatever I've drawn will give him about 30 grams of protein, which is very safe, and the patient will be quite happy. Now, this is for the North Indian patients. The same, but a slight difference. Now, moving on from very simple low protein diet to a very low protein diet. That is, very low protein diet is 0.3 grams per kg body weight per day. When it is combined with keto analogs, it reduces uremic symptoms, reduces proteinuria, preserves residual renal function, slows down rate of progression of disease, delays initiation of dialysis, lowers EPO requirement. There's better control of blood pressure. Studies have shown that it lowers indoxyl sulfate levels compared to usual protein diet, which is 0.6 grams per kg body weight per day, and improves metabolic acidosis and preserves nutritional status. So MDRD study was the biggest study that came up with these results, that when you combine keto analogs with very low protein diet, it is beneficial to the patient. So here you can see that when you combine keto acids with very low protein diet, the proteinuria decreases, the metabolic acidosis improves, the serum phosphate levels come down, and the triglycerides also decrease. And we at SGPG did a randomized controlled clinical study on the alpha ketone analogs, and we found that in the supplemented group, the GFR was well maintained, the serum albumin was well maintained in the supplemented group compared to the controls, and the hemoglobin increased and the blood sugars came down in these patients. And so what will you give your patient when you want to give very low protein diet with keto analogs? We gave 0.4 grams per kg body weight per day of protein with 6 tablets of keto analogs. The MDRD study proposed 0.3 grams per kg body weight per day of protein, along with 9 to 10 to 12 tablets of keto analog. But we adjusted this, and we got very good results. But then you have to remember to prescribe high calorie diet to your patient, because when you will cut down on protein, definitely the calories will also get cut down. So you can always resort to giving your patient sabudana, that is tapoika sagu, which is very rich in energy, but it is low in it has zero protein. So for this, all you have adjustment that you have to do is you have to cut down on the quantity of sambar that you give to your patient. Otherwise, the whole menu remains the same. Now, moving on from pre-dialysis to dialysis stage, when patient is on maintenance dialysis, from metabolic point of view, each dialysis session decreases plasma amino acid levels and blunts intracellular protein synthesis. So when a patient is on hemodialysis, on each session he loses 1 to 3 grams of protein, and when a patient is on PD, then in 24 hours he can lose between 5 to 15 grams of protein, which is about, an average is about 10 grams, depending upon what is his transport characteristic, whether it's a low transporter, high transporter, or high average transporter. Now, if a patient has peritonitis, then he can lose between 15 to 48 grams of protein every day. Now, this study by Chung et al. Has shown that if malnutrition is present at initiation of dialysis, it is a strong predictor of subsequent increase in relative risk of death. And so you can see that patients who have normal nutritional status, they have a better survival compared to malnutrition, which in other words means that your patient should not be malnourished at initiation of dialysis at all. And Canuza's study has also shown that relative risk of death increases as serum albumin decreases and worse nutritional status. So, keeping this in mind, the KDOQI guidelines have recommended that the pre-dialysis or stabilized serum albumin should be more than 4 grams per deciliter, and the pre-albumin should be more than 30 milligrams per deciliter. And the rule of the thumb is the reverse protein loss. Give high protein diet to patients on dialysis, and at least 50% of this protein should be of high biological value. Now, coming back to the same table that you've seen again, this is the non-dialysis CKD patient. And here we're going to talk about the hemodialysis and patients on peritoneal dialysis. Now, in non-dialysis patients, you are giving them 0.6 grams per kg body weight per day of protein. In hemodialysis patient, you just have to double the amount of protein. That is, it becomes 1.2 grams per kg body weight per day of protein. And in peritoneal dialysis, if the patient is not clinically stable, then you give him 1.3 grams per kg body weight per day of protein. And if the patient has peritonitis, prescribe him 1.5 grams per kg body weight per day of protein. And the remaining everything is just the same. So in order to prevent muscle catabolism and preserve nutritional status in patients on dialysis, double the amount of food prescribed during pre-dialysis. Prescribe them high protein, 1.2 grams per kg body weight per day of protein, and 30 to 35 kilocalories per kg body weight per day of energy. If you give your patient, say, about milk 150 ml, curd 200 ml, and 2 egg whites, chena or paneer 100 grams, dal or sambar 2 bowls in a day, and chapatis or rice, then the patient can actually get about 50 grams of protein from the food, and the remaining deficit should be given through oral nutritional supplements. It is important to keep your patients on oral nutritional supplements. Now, in order to increase protein, as I just mentioned, protein and energy intake, prescribe renal-specific oral nutritional supplements for patients on maintenance dialysis, because renal-specific oral supplements have low sodium, low potassium, and low phosphorus. Now, in patients of peritoneal dialysis, the patients absorb glucose from the dialysate, which induces satiety, abdominal discomfort, and they have suppression of appetite, because each patient absorbs about 100 to 200 grams of glucose every day, which gives them about 300 to 500 kilocalories per day. That is about 19 to 20% of the total energy that they're going to take. So therefore, because of abdominal discomfort, advise your patient to take small but frequent meals, and also adjust energy that is obtained through dialysate in the diet prescription. Now, here we did a study, a multicentric randomized controlled trial on protein supplementation. We gave them 70% protein, and we found that in the supplemented group, the green bars, here you can see, the protein intake increased significantly. The serum albumin levels increased in the supplemented group, and also the skin folds also increased in these patients. You can see the green bars. Now, as you increase protein intake, the serum phosphorus levels also increase, because 1 gram of protein contains 13 to 15 milligrams of phosphates. And therefore, KDOQI guidelines recommend to normalize phosphorus in CKD stage 3 to 5 through dietary measures and non-calcium containing phosphate binders. So the recommended dietary phosphorus should be 800 to 1000 milligrams per day, and one must prefer vegetable protein, because only 40 to 60% of phosphates from the vegetable protein are absorbed compared to the animal protein, which is organic, and about 80% of it is absorbed. Now, prescribe foods low in protein phosphorus ratio, because here you can see as the protein phosphorus ratio increases beyond 14, there is twofold increased risk of death in the patients. Now, egg white is an unusually rich source of high biological value protein and has one of the lowest phosphorus protein ratios, and is also devoid of cholesterol, so you can prescribe egg white very safely to your patients. Now, avoid foods with phosphorus-based additives like cola beverages, enhanced or restructured meats, frozen meals, cereals, snack bars, dry fruits, processed or spread with cheeses, instant products of refrigerated bakery products. Now, blood pressure is extremely salt sensitive, and achieving low blood pressure level is fundamental to limiting progression of renal damage. But what happens is high salt intake decreases anti-albuminuric effect of anti-RAS agents and antihypertensive pharmacological intervention, and also aggravates course of renal damage. But the mechanisms are not related to blood pressure. So, low salt intake should be the basic approach to hypertension in CKD. The JNC7 recommends sodium restriction should generally be enforced in all CKD patients to less than 2.4, and if blood pressure is uncontrolled, then 1.5 grams sodium per day should be given to the patient. And gradually reduce salt and monitor salt intake with 24-hour urinary sodium excretion, and decrease animal protein intake. And here you can see what is the best measure of salt. Take 1 level teaspoon of salt that contains 5 grams of sodium chloride, which means it contains 2.5 grams of sodium. So you can give 1 level teaspoon of salt to your patient. And patients must avoid foods containing sodium, which is more than 100 milligrams per 100 grams, and foods which contain salt as preservatives like canned foods, fruits, pickles, fruit jams, salty processed cheese, and meat. Prescribe low potassium diet to prevent hyperkalemia. And here you can see that you can prescribe apple, banana, guava, pear, papaya, and pineapple to your patients. And also vegetables and fruits are very rich in potassium, so therefore you have to advise your patient to leach or remove potassium from the vegetables. For that, all they have to do is they have to soak chopped vegetables in lukewarm water for half an hour, or what they can do is they can boil chopped vegetables for 5 minutes or 10 minutes and then decant off that water, and then you can use them. Now, ragi is very rich in potassium, so therefore discourage your patients from taking ragi products. And also drumsticks are very rich and very high in potassium, but 1 drumstick or 2 drumsticks can be added to the sambar, because I know in South India sambar is a favorite thing for you, as dal is for North Indians. So patients must avoid green leafy vegetables, soup, green leafy vegetables, ragi, drumsticks, tomatoes, sweet lime, lemon, carrots, raw salad, mangoes, dry fruits, fruit juices, vegetable soups, because these are concentrated in potassium, and coconut water. Now, metabolic acidosis also causes protein catabolism. Therefore, supplement sodium bicarbonate to slow progression of CKD and to preserve nutritional status. Here you can see when you supplement sodium bicarbonate, the plasma bicarbonate levels improves, the urinary sodium excretion improves, the blood pressure control improves, and the patient has a dialysis-free survival for a longer period of time compared to controls. And this study showing you that there's an improvement. This is a study by Zetto et al., that there's improvement in the nutritional status of the patients who are kept on sodium bicarbonate. So the current guidelines recommend treatment with alkali if bicarbonate levels are below 22 mmol per liter, and it should be evaluated every month. And sodium bicarbonate should be supplemented as 0.9 milliequals or 1 milliequal per kg body weight per day with the diet which is rich in fruits and vegetables. But in our case, fruits and vegetables we can't give because of the fear of hyperkalemia, so we have to restrict fruits and vegetables, but the patient should be on a low protein diet. And also patients who are fond of having idli and dosa, they can add sodium bicarbonate to the batter, and they can have a continuous supply of soda bicarb. Now, CKD is characterized by persistent low-grade inflammation, and we know that inflammation causes the progression of CKD. The CRIC study has recently shown that high circulating levels of fibrinogen, TNF-alpha, and IL-6 and decreased serum albumin are independent predictors of decline in GFR. And the reduction in the study was 50% in the GFR from baseline. So we need to have an early intervention in the you can use pharmacological agents. But if you want to resort to dietary intervention, then prescribe them turmeric, 2 teaspoons a day, which has anti-inflammatory, anti-tumor, and antioxidative properties. And do advise your patients to take ginger, green tea, lemon, raw oats, red bell pepper, extra virgin olive oil, pineapple, yogurt, apple, and brown rice, because these are all anti-inflammatory foods. I would again tell your patients to take more of green tea, because green tea is not only diuretic but has very low potassium and sodium and phosphorus, and therefore it's better than having a normal tea. Now, hypoglycemic state exacerbates CKD progression, and either directly or indirectly through vascular complications. Hypoglycemia increases oxidative stress, and formation of ages as a product of oxidation of carbohydrates increases hypoglycemic state. So advise your patient to take small meals at frequent intervals, which should have low fat and complex carbohydrates. The aim of nutritional therapy here is to achieve normal glycemia. So the random blood sugar should not be more than 150 milligrams per deciliter. Manage dyslipidemia. Tell them to avoid high cholesterol foods and restrict cholesterol to less than 200 milligrams per day, and avoid and prescribe them omega-3 fatty acids, that is fish. According to AHA, patients should take fish twice a week, but we discourage our patients to take animal foods because they, in the end, leave acid ash and that increases metabolic acidosis. Now, weight management should be done through adjustment with the calorie intake, that is less than 30 kilocalories per kg body weight per day. Now, protein for a patient with diabetic nephropathy, you can start giving them protein at 0.8 grams per kg body weight per day, but as GFR declines, decrease it to 0.6 grams per kg body weight per day. And patients should have a good blood pressure control, that is less than 125 by 75 millimeters of mercury, and bring down proteinuria with the use of ACE and ARBs. Now, vegetarian diets increase insulin sensitivity, and stringent control of blood glucose early in the course of diabetes mellitus significantly delays onset of microalbuminuria. Now, factors that cause an increase in oxidative stress are malnutrition, inflammation, and decrease in oxidative defense mechanism. So, prescribe apple, blueberries, bell pepper, onions, garlic, and corn to your patients because these are very good antioxidants. And treat anorexia. Eliminate or treat any potentially reversible or treatable condition or medication that might interfere with appetite or cause malnutrition. For instance, phosphate binders induce loss of appetite. So you can discontinue phosphate binders for a week or 10 days. And then as appetite is resumed, you can again start phosphate binders. You can use another brand of phosphate binders. Similarly, iron supplements and calcium supplements can cause GI upsets, and calcium supplements particularly cause irregular bowel movements. So you can plan something accordingly and see that patient's food intake doesn't suffer. But doesn't mean that the patient, you keep the patient hypocalcemic. That's not true either. And also, because our patients have a lot of pill burden, reduce salt intake for better control of blood pressure, in order to minimize requirement for antihypertensive medication. And lastly, avoid greater renal injury by preventing volume depletion in these patients. So the take-home message for this talk is prevent and monitor progression of renal dysfunction. Prescribe low protein and very low protein diets combined with ketone logs to reduce proteinuria, inflammation, and oxidative stress. When prescribing low protein diet, increase calorie intake judiciously, as increasing calories can increase insulin resistance and impair carbohydrate and lipid utilization. Prefer plant protein over animal protein. Unregulated amounts of dietary phosphates or sodium chloride interfere with the ability of ACE inhibitors to suppress progression of CKD. Restrict phosphorus intake through vegetarian diet and advise use of phosphate binders with meals. Prescribe high protein diet to patients on maintenance dialysis and prevent metabolic acidosis and treat inflammation. And thank you for your attention.